Hello, I'm Dr. Robert Brown from Weill Cornell Medicine in New York, and I'm here to discuss patients' options when they come off obeticholic acid or Ocaliva and want to think about second-line options. For many of our patients, coming off Ocaliva is going to be stress-inducing. If you've been doing well on the therapy with a good biochemical response and no side effects, it can be daunting to think about stopping a medication that has been working and potentially slowing the course of PBC. But I think the reassuring thing is that there are second-line options. What I've been telling my patients is two things. One is if you've been doing well on Ocaliva, you have nothing to worry about. It has been working. Your disease has been slowed. And yes, when we stop Ocaliva, you will lose a biochemical response. The alkaline phosphatase will likely go back up to its baseline level within months after stopping. But that doesn't mean that any of the benefits that you've gotten over the years on Ocaliva are going to be lost quickly. PBC is a slow disease, and in general, we have time to make decisions. And really, you have two decisions to make with your doctor. First, do you want to come off Ocaliva and watch what the response is? Does your alkaline phosphatase go up? How much? And do you want to start a second-line option? Or do you not want to take any chance of rebound and switch directly to a second-line option? This is certainly a reasonable choice and one that you can do. There are two FDA-approved second-line options, seladelpar and elafibranor. Both are PPAR agonists, so they have a different mechanism of action from Ocaliva. So that has pluses and minuses. Obviously, the benefit is a different mechanism of action may work better than Ocaliva was working. By the same token, it may not work as well. And the side effect profile of both seladelpar and elafibranor are similar to one another, but different from Ocaliva. There are certain things that are more beneficial. Certainly both seladelpar is FDA approved to both reduce alkaline phosphatase and reduce itch. Elafibranor has been shown to decrease fatigue. So your doctor and you may choose your second-line agent based on multiple factors, which is preferred by your insurance and may have a lower copay for you, which one has a side effect profile that is better fit to your preferences or to the underlying symptoms that you may have. And finally, they may choose to just take you off Ocaliva and watch and see. All of these are reasonable options. But what I tell all my patients is they should be happy for any benefit they got from Ocaliva. I did not see any safety signal since the FDA meeting, and my patients who had been stable on Ocaliva have stayed on Ocaliva till now, and I'm working through with each of them their options in terms of switching therapy, stopping therapy, or stopping and then starting a new therapy. For most of my patients who I believe had indications for second-line therapy, I'm choosing to try to switch them directly to one of the FDA-approved PPAR agonists without a washout period. There is no need to taper off Ocaliva, nor are there any issues with switching directly from Ocaliva to a PPAR agonist, either seladelpar or elafibranor. We don't need to have any overlap, but similarly, we don't have to have any washout. So there are new options, and if one of the new PPAR agonists doesn't work for you, there are other agents in development. And so all of our patients should know that we have other therapies for them, that we will be able to treat them, and that there are newer treatments in development should we have an issue and need to do it. I hope this has been informative and has helped allay any of your concerns about coming off Ocaliva. Thank you for your attention.